Well, good morning, everybody. As I was saying earlier, really do appreciate the time this morning that you joined us, and we're really excited about the material we're about to show you and share with you. As ReddyPort, we have had a lot of questions and interest in the whole idea of the awareness of non-ventilated hospital-acquired pneumonia, NV-HAP, as you know, and its impact on hospitals, patients, and healthcare workers. And more specifically, we're hosting this session because too often oral care and oral care for BiPAP patients is viewed not as essential health care, just comfort, and to address the need to give nurses the proper tools to do their jobs. So this morning, we're honored to present two distinguished luminaries in the field of NV-HAP and oral care's critical role in NV-HAP prevention, Barbara Quinn and Marcia Cornell. Barbara is well known for her clinical research on the epidemiology of healthcare-acquired pneumonia and the preventative effect of oral care. Barbara has authored several resources, including the AACN procedure on oral care practices, and is the lead author of the American Journal of Infection Control's Best Practices for Prevention of NV-HAP and many other articles and studies. Marcia Cornell is the senior clinical nurse specialist for a large 14-hospital network that has implemented a successful system-wide oral care initiative. Marcia is a passionate supporter of mouth care, has conducted research on oral care's impact on pneumonia prevention and thereby readmissions related to pneumonia or sepsis caused by pneumonia, and has extensive experience in emergency care and trauma services, and gaining more and more leaders at the various campuses to implement a system-wide and overcome the challenges. So we're really excited to have these two distinguished leaders in this field present information to you. A couple of housekeeping from your perspective. As you know, this is being recorded for future use, and it'll be available via our website very, very soon. Feel free to ask questions via chat. It's important that we do the best we can to make this as relevant as possible and to answer your questions. So with that, Barbara, I'm going to hand it over to you, and let's go ahead and begin.
Everybody, and it is such a pleasure to be with you. I thought I would start, well, first of all, I'm always really privileged and excited to share about something that all of us as nurses can do to protect our patients. So I'm passionate about that, keeping them safe when they're under our care. I'm also really excited to be presenting this morning with my friend and colleague, Dr. Marcia Cornell. We met, and you'll hear a little bit about her story after me, but this is really, really fun for us to be able to talk together and share. We've been working together sort of separately across the country for years now. So this is truly a privilege. I thought I would start by sharing my story about how I first got involved with NV-HAP before we move on to the rest of our agenda today. My journey with NV-HAP, non-ventilator hospital-acquired pneumonia, really started with one question by one nurse in one ICU unit in one hospital. And she asked me, Barbara, do we have a problem with pneumonia, hospital-acquired pneumonia? And we were in the ICU. I assumed she was talking about ventilator associated. I was a brand new clinical nurse specialist working in the quality department. And so I was rounding on some quality things, making sure that patients were getting all the care they needed for the bundles. And when she asked me that, I says, well, are you talking about ventilator-associated pneumonia? She goes, no, I'm talking about the patients who come into the hospital for one thing, like a hip surgery or pancreatitis or whatever, and then they end up getting pneumonia. And as part of RRT, she was having to go down and rescue them, bring them up to ICU. She goes, it just seems like it happens a lot. And as a good new clinical nurse specialist, I went to the literature and I looked and I couldn't find anything. And I asked my boss, she goes, Barbara, that is not one of our metrics. We don't look at that. And nobody seemed to know whether we had non-ventilator hospital-acquired pneumonia occurring or not. And so that really led me to my first study, because when there's a gap in the literature and nobody knows the answer, then that's a good time to do a little research. So I got my first grant, and I was able to do a 1-year retrospective review in just my one hospital. And in that first year, when I looked at the data, we had 115 non-ventilator hospital-acquired pneumonia, and that was unreported, right? Nobody knew that that was going on. And that came out to like $4.6 million in extra costs, 500 extra days in the hospital, and the mortality, the all-cause mortality for that data was 29%. So you can imagine that I was quite alarmed, and that led me on in this journey. What you see here is the first article that we published. That was back in 2014, hard to imagine. Actually started working on this in 2010. Here we are 14 years later. And in some ways it feels like we haven't gone nearly far enough, but in other ways we have come very far. At least people know what it is now. So I know we're making progress, and we have all you on the line today listening and having questions that you would like to have answered. So with that, I'm going to hand it over to my friend and colleague, Marcia.
Good morning, everyone. To share my story and how did I get started in this, a few years back, I was leading the readmission prevention task force at my hospital. And part of readmission prevention is you got to figure out, why are patients coming back, right? So looking at why patients were coming back, I was initially looking at the visit reasons and noticed that quite a few patients were coming back with respiratory related complaints. Digging down into it further, was seeing a trend that secondary admission was related to either a pneumonia or sepsis related to pneumonia. And it was in particularly with the COPD patients. I saw it over all patients, but in particularly with COPD, it would be like this trend. They come in with COPD, and they're back with pneumonia, and then it's sepsis because of the pneumonia. So I was just really perplexed by this and like, what do we do? How do we stop this cycle? And I saw Dr. Quinn present at our NACNS conference in 2017. And I was so excited to hear the presentation, like, all right, she's going to tell me the answer. And she did. And it was that golden ring it's oral care. And I was like, wait a minute, why didn't I think of this? Because I had helped another CNS at another facility do some research related to how often should we brush the teeth of the ventilated patient. I was like, duh, this only makes sense. Why didn't I transfer this over to the non-ventilated patient? And that the answer was that we need to provide standardized oral care. So that's really what got me involved with this, and just following along with all of the work that Barbara Quinn and Diane Baker and all of the other different research has been doing, has really been led what my work. So we're going to get into the various different discussions then. And so these are the questions that Barbara and I both receive generally overall with our work. And so these are some of the topics that we are going to discuss today. Talk on the clinical risk and the costs of the non-ventilator hospital-acquired pneumonia, or NV-HAP. What's the current research and recommendations regarding preventing NV-HAP? Why is oral hygiene so crucial to it? Talking about the evidence care program, what steps you can take to get buy-in from administrators. We'll share a little bit of our stories as to what we've done, and talk about the future of NV-HAP prevention, and of course try to answer some of your questions. We've had some questions submitted to us prior to, and we'll also be monitoring the chat. So Barbara, can you tell us more about how you got involved and how much this was a national concern?
Yeah, Marcia, thank you. I have been really amazed and very pleased in how quickly this has been building, and especially the last 5 or 6 years. I went into PubMed just for the heck of it and put NV-HAP in there and found that just in the last 5 or 6 years, there have been over 70 PubMed publications that have to do with NV-HAP. So when we see something like that and an exponential growth in the literature, we know that there's definitely interest and concern. So what I thought I would do is share a few of those key pieces of literature with you to show you how this has been building over the last several years and why we need to really be paying attention to this. I would say in 2018 was a landmark study. Every so often the CDC does a point prevalence study to see where we are with healthcare associated infections in our US hospitals. And the latest one they did was published in 2018 and found for the first time that hospital-acquired pneumonia was the most common hospital-acquired infection. The device-related infections had improved, but non-device related infections had not. And in fact, 2/3 of those hospital-acquired pneumonias were non-ventilator hospital-acquired pneumonias. So we knew that was really important, and that made people sit up and notice a little bit more. In fact, in the Association for Professionals in Infection Control, APIC is what I call them, they asked me to help them write their first practice position statement on non-ventilator associated pneumonia. So I was thrilled to be a part of that, along with some other researchers. And then the next year, they came out with a whole supplemental issue, a non-ventilator healthcare associated pneumonia implementation guide. So there's multiple chapters and covers everything you'd ever want to know about the populations and how to prevent it. That was really important, I think. And then in 2021, there was actually a call to action from an organization called NV-HAP, National Organization to Prevent Hospital-Acquired Pneumonia. Big players in that was the VHA, and lots of really well-known researchers, including my friend Dr. Baker and Dr. Giuliano, as well as Barbara Jones and Dr. Michael Campus. One of the authors and collaborators with this call to action, in addition to CMS, the CDC, and the American Dental Association, was the Joint Commission. And within a few weeks after this call to action was published, they put out a quick safety issue called Preventing Non-Ventilator Hospital-Acquired Pneumonia to make it very clear that the Joint Commission was indeed looking at this and really made a strong call for prevention programs and monitoring of NV-HAP. In 2022, we saw the first large patient safety organization, ECRI, publish something every year. They put out a list of their top patient safety concerns, and for the first time in 2022, they included NV-HAP. And then towards the end of that year, the strategies to prevent hospital-acquired pneumonia were updated. They do that every so many years as new evidence emerges. And for the first time, you can see here in the yellow, they added non-ventilator hospital-acquired pneumonia. Up until 2022, that had really been left out of the national guidelines and practice recommendations. So you can see over time how this is growing, and people, not just people like Marcia and I, but entities across the healthcare continuum are really sitting up and taking notice. So that tells us as clinicians that we need to be paying attention. So we know it's happening, we know there's a lot of interest, but what exactly is the impact of NV-HAP? I wanted to spend just a few minutes summarizing some key studies for you that really speak to the incidence, length of stay, and other quality metrics. So in 2023, there was a study published by Dr. Barbara Jones and Dr. Michael Campus. A very large study. They looked at 284 US hospitals over 2 years' time and analyzed over 6 million patients. So talk about a robust database, right? And what they found was they found an incidence of NV-HAP of 1 per 100 to 200 patients. They found length of stay was 16 days versus 4 days for similar patients without NV-HAP. And the mortality was striking to me. The all-cause they found was 22%, but it's one of the first articles that's really looked at attributed deaths from NV-HAP, and they found 7.3% of all hospital deaths were attributed to NV-HAP, and it came out to about 1 in 14 deaths in the hospital just because somebody got NV-HAP. That to me was really impactful. And of course, the cost is about $40,000. Marcia and I were talking about this the other day. There's quite a range of cost, and that's because the cost is very much based on how long the patient has to stay. And as we know, there can be a wide range of that. I've seen it the cost everywhere from $13,000 to $165,000. So most articles quote about $40,000, and that's probably a good round number if you're looking to extrapolate what the cost is in your hospital. There was another study that Dr. Baker and I did. It was a 21 hospital national study. And one of the things we found, besides all the same things that Dr. Klompus found in his study, was how NV-HAP affects ICU utilization. We found, again, 3/4 of NV-HAP occurs outside of the ICU. But of those, 1/4 of them had to be transferred to ICU to a higher level of care because of their pneumonia. And we found that 46% of all patients with NV-HAP needed some ICU care. So when you're talking about cost and impact of NV-HAP, of a preventable infection, ICU utilization should definitely be on your list of things to be watching. We also found a readmission rate of 19%. That's 1 in 5 patients who get NV-HAP will return to the hospital. And interesting, we're talking a lot about sepsis right now. We're talking a lot about early recognition and treatment, but I'm wondering, should we be looking at prevention? Just like Marcia was saying, we can prevent readmissions if we prevent sepsis, and we can prevent sepsis by preventing pneumonia. There was a large study that was done a few years ago by Dr. Baker and Dr. Giuliano, and they looked at a whole year of all the Medi-Cal patients in the United States. So lots of patients, 170,000 of them about developed NV-HAP. And of all those NV-HAP patients, 36% of them developed sepsis. That really goes along with other sepsis literature that shows that 40 to 50% of all sepsis initiates from pneumonia as the site of infection. So definitely very, very large impact.
And so that's a question that we received from Douglas Johnson from the VA, is how prevalent is sepsis because of poor oral care? And as we were going to be talking through here about the etiology and the big intervention of being oral care is the key intervention. So you can extrapolate, so that 36.3% risk for sepsis because of the pneumonia. So definitely an important piece there. So hopefully that answers your question there. So the etiology of pneumonia. So we need to have basically all 3 of these components that put this at risk. Understand all of these causes that potentially cause the hospital-acquired infection, and develop the interventions to address these risks. And when we have all 3 parts, they have that increased risk for, like we said, the hospital-acquired pneumonia. So with pathogens in the mouth, I love this infographic. A lot of folks are just shocked by this. And when you understand that the microbiome replicates 5 times in a 24-hour period, and studies have shown that within 24 to 48 hours of hospitalization, the microbiome has common pathogens that could cause a pneumonia. So if they're aspirated, they could potentially cause a pneumonia. And that's the second thing that is puts our patients at risk is the aspiration. That saliva escapes into the trachea, and we all microaspirate. You and I here individually, we're healthy individuals, right? And about 1 milliliter of saliva carries about 100,000 microorganisms. That is plenty for an inoculation or potential causing of a pneumonia. And the weaker the individuals are, when they have a weakened immune system, disrupted physiological defenses, the sicker they are. Essentially, the sicker they are, the higher the risk they are for aspirating, because we've given them different medications that might sedate them. They might have a lower level of consciousness. They're not up out of bed. They're not having their head of the bed elevated. They may have decreased nutrition, etc. So all of these different functions could potentially cause them to have weakened defenses to fight off an infection. And so one of the other questions that we received was, what demographic does evidence point to that are the highest risk for developing oral infections? Well, we can't really get into the oral infections per se, but we do want to focus on those high-risk patients that have are weakened defenses. So our patients that aren't getting up out of bed, we need to get them up and moving. So this is what we got to look at, is we need to look at what are the modifiable risk factors that we can address. So when we talk about our primary drivers, we want to reduce our oral pathogens, reduce our aspiration issues, potential issues, and we want to strengthen our host defenses. So the number one issue is reducing the oral pathogens. As you saw that picture with all the germs and the 5 times 24 hours, how our microbiome replicates, we want to do good oral hygiene to address that. We want to address the aspiration issue by identifying dysphagia, doing our swallow assessments or risk screening, elevating the head of the bed, avoiding intubation, minimizing sedation, etc. We also want to strengthen our host defenses. We want to get them up and out of bed, get them moving. We want to make sure that they have adequate nutrition. Work on glycemic control, to control that glycemic control. And one of the other questions we get is asking us about best practices for completing oral care and where do these guidelines come from. Well, this guideline here and key driver is a streamlined key driver, again, going back to that 2020 APIC implementation guideline. And it's also produced in the American Journal of Infection Prevention, the supplement in May 2020. That's your guide. That's like your roadmap for you if you need to implement a program. And so Barbara, can you tell us a little bit more as to why we focus so much on that first initial one about oral hygiene?
Right, and thank you, Marcia. That was a really good overview of etiology and prevention. It's important for us to know what causes it, right? Because then we know what we can do. We can identify those modifiable risk factors. The reason that we talk about oral hygiene as a key intervention for this is because, number one, it's the only intervention that addresses source control. Of all the things we can do, mobility and reducing aspiration, all those things, very important. But the only intervention that addresses source control, and when you're talking infection prevention, and those of you on the line who are infection preventionists, you know that that's where you go first. And so that's one of the reasons that I believe oral hygiene is a key. Oral hygiene also has the most studies of all those interventions, and that also has the most evidence of effectiveness of all the studies. And when they compare which interventions are most effective to prevent pneumonia, oral care is always rising to the top. And then, as I mentioned, the new guidelines from SHEA, IDSA, and APIC that came out in 2022, they added daily oral hygiene as an essential strategy to prevent pneumonia. So that just validates what we've been saying all along. And the good news is, and Marcia, you know this, is that there's a lot of studies out there now that show that oral hygiene truly does prevent pneumonia. There are several implementation studies. This is the first time I've ever put this summary slide together, and I got real excited just doing it, reading over all those studies and the great results that people have gotten. So the one I spoke about in 2014, we got oral care frequency up to 3 to 4 times a day, and we saw a 37% reduction in our NV-HAP. Warren did a study in 2019. Giuliano did a study back east with Dr. Penmore. They found an 85% reduction. They were just looking at medical patients in the ICU, so a little bit specific, but or not in the ICU, out on the units, excuse me. But they saw a really remarkable reduction. And you can see those top 3 only used oral care as their only intervention for these results. The last 2 lines here are several studies that are out that use some sort of a bundle. So they did some sort of oral care bundle, or they did a pneumonia prevention bundle that included oral care. And you can see the outcomes were really quite similar to what we've seen in oral care as the primary intervention. So what that tells me is bundles are great, but if you have to choose one intervention, I definitely would choose oral care. It's basic, it's not going to harm the patient, it's low cost, low tech, and it's something that everyone agrees should be, I mean, everybody should be getting their teeth brushed. So I did get a question from my friend Pat Posa. Hi, Pat, if you're on. She wanted to know what the optimal frequency for oral care was. We get that a lot. I found in my study that as we got up to about 3 times a day that we saw a bigger reduction in NV-HAP. Some do more. Karen Giuliano did 2 to 3 times a day, and they had obviously a very remarkable reduction. There's only one study that I know of for sure, and it just came out recently by Aaron Zeller, and they did a systematic review of the randomized controlled trials of oral care to prevent pneumonia, and they compared oral care with toothbrushing to oral care without toothbrushing. Oral care with toothbrushing was significantly better to reduce pneumonia, and they found the frequency of 2 times a day was sufficient, and 3 times a day wasn't any better than 2 times a day. So that's the first time we've seen that. That was not my experience, but when you're talking about a systematic review, that trumps one study. So I would say a minimum of twice a day brushing. Now in ICU, patients with dry mouths, you may want to do some moisturizing in between, but at the very least, twice a day is what we would recommend based on that. So Marcia, you've had more recent experience than I have on being in the hospital. What would you say an evidence-based oral care protocol looks like so clinicians know where they can start?
So what I basically went back to again is what I call the roadmap that you have provided. You and your team, your other esteemed colleagues have provided in that American Journal of Infection Control implementation guide from May of 2020. Gives you definitions here. The first column here defines our patient populations, our independent patients who are able to provide oral care for themselves, like you and I. Then there are the patients that are dependent. They are not able to expectorate. They're higher risk for aspiration. So they need us to do their oral care for them. And then the dependent ventilated patient. And what I like about this too, we also included those patients about dentures. What do we do about dentures? And this tools here are all the various different tools that you would need to utilize for those types of patients. What I find is interesting here is that I didn't know until we started working on this, is that you and Dr. Diane Baker had put together and reviewed over the type of tools that you needed for each of these patient populations and had it reviewed by the American Dental Association in 2017. So we're not depending on any specific product, but we are following the guidelines from the American Dental Association for oral care. Talks about the procedure, and this is where we talk about the frequency of the 2 to 4 times a day. And when I teach to it, I go back to that picture again about how our microbiome multiplies 5 times in a 24-hour period. So if it multiplies in a 5 times of a 24-hour period, the more often that we clean it, the better off we're going to be. So the 2 to 4 times, and that's what we use in our protocol here. The reason why we have here the section highlighted in red under the dependent ventilator, at the time that this came out in 2020, we were still utilizing across the nation the CHG, the chlorhexidine, for the ventilated patient. But with the SHIA guidelines or SHIA guidelines, however you pronounce that, that came out in 2022, the recommendation from those guidelines was to de-implement and no longer use the chlorhexidine for the ventilated patients. So that was one of the biggest things. So one of the things that we had noticed in 2020, is our wonderful year that came out with COVID and brought to our attention that when we look at these patient population, that there's another patient population that we maybe didn't think about or delineate out in this, and that is our non-invasive ventilated patients, or patients that are on BiPAP. And we started utilizing BiPAP so much more during COVID, et cetera, because while BiPAP, it does not utilize an invasive airway, we can still use pressure to help support the work of breathing, avoid intubation, and improve survival in these patients that are having acute hypoxic respiratory failure, and help promote them with the oxygenation. One of the risks, though, is that with the pressure, we might be potentially pushing those pathogens further down into the airway as well. And one of the studies that was shown is in the Zhang study was that 3.1% of non-invasive ventilated patients have a higher incidence of the NV-HAP. And it also increases a longer ICU stay, 10.8 versus 7.9 days, longer hospital stay of 25.9 days versus 15.3, and higher intubation rate. So as we know, these are patients that are generally sicker, and we end up going to be intubating them. And then also they have a higher mortality rate, 75% versus 25% of patients that are not non-invasively ventilated. So this is definitely an area that we want to consider and look at, and what can we do for these patients as well. And so we need more than a great oral care protocol to change behavior. Besides, all right, we need to do it, but how do we do this? And how do we get that change behavior working? So some of the different elements that we might want to talk about regarding an oral hygiene program is overall educating to the evidence that your program is based on, and you're using the evidence-based practice, gap analysis. Prior to the 2020 implementation guide that came out, working with Barbara Quinn with information she was sharing out, the gap analysis coming back. Big thing is just looking at your tools and looking at your data and your processes. Do you have a policy, procedure, or a guideline? And just main thing is looking at your equipment, and if you have the right equipment to do the job. How do you document it? Any other resources that you have? And how do you implement change? And so, Barbara, where did you start to implement change at your facilities?
Thank you, Marcia. I always start with the gap analysis. And in particular with this project, I felt like it was really important because I needed to show my facility and the leadership that I truly was following best practice and making decisions about what we needed to change. So my gap analysis always starts with the best practice. I try to keep it pretty specific on the left-hand side, and then I do an assessment to see where we are, our current state, and then design an action to take and when to get that completed by. Obviously, this is old from 2012, so you'll see some things in here. I would just say, for example, a best practice we knew from the CDC in 2003, comprehensive oral care protocol for all patients. That was best practice clear back in 2003. And what I found at our hospital was the only care protocol we had was for our ICU patients on events. So Marcia, who in our hospital do you think was getting oral care? It was just those vent patients, and the others it was not a priority at all. So we knew we had to develop that. The second one here, interestingly, back in 2012, CHG was still the vogue. And what I found was that we weren't using CHG during the perioperative period on adult CV patients, which is still in the literature, by the way. Those cardiac surgery patients still benefit from the chlorhexidine perioperatively, as well as, and at that time, the vent patients. So we weren't using it, so we put that in place for those patient populations. And then the oral care supplies, I don't know about you, Marcia, but that was a huge eye opener for us.
Definitely.
When we looked at what is recommended in the American Dental Association for healthy people, right? And then what compared it to what we had in the hospital, it was shocking. So I found these little white toothbrushes that would bend and the bristles would fall out. They told me they were disposable, but it's like they should have been thrown away before the patient used them. I think they were so poor. And we had some sort of Sparkle Fresh toothpaste.
We had mint flavored blue water. Our oral rinse had no antiseptic in it.
We had that too. Oh, it was, and that's where they had it. If they had it, it was that. And every unit was a little bit different at our hospital. Some had things and some didn't. The other thing we found was zero denture supplies. We didn't have a denture brush. We didn't have we used a little kind of container to keep them in, but we didn't have any cleanser for them or anything like that. So boy, we had a lot of work to do. And this was the gap analysis that we used to sort of get there. And besides knowing best practice, current state, and putting a plan together, I can't stress enough the importance of having the data. And we need to measure both process and outcome. And everybody wants to know, okay, how are you going to measure NV-HAP? I'll talk about that in a minute. But don't forget the process, right? And if we're looking at oral care, you want to know, is oral care occurring? So these are the charts I put together, and sometimes I overlaid them so that the staff could see as they increased the rate of oral care, the frequency, then they decreased the incidence of NV-HAP. That was really, really important to them. Speaking of CHG, for our CV surgery patients, you can see what happened on the right-hand side. Our cardiac surgery patients with NV-HAP went down to 0 when we started doing CHG perioperatively. Now, keep in mind, they weren't getting any oral care preoperatively. So was it the toothbrushing or was it the CHG? I couldn't tell you from this data, but definitely you really want to collect both process and outcome metrics. For the oral care, we audited the charts, looked at the chart documentation, and then we would also go in the patient rooms because just to validate what we saw in the documentation. I don't know if you did that, Marcia, but we found very interesting things in the patient rooms, like no toothbrush or toothbrushes still in the plastic and not used. So it was a really good opportunity to do some just-in-time teaching. And then for our NV-HAP, it's the same. Okay, for NV-HAP, there has been no easy way to measure NV-HAP, and I think that's been one of the biggest barriers to CMS making it, putting some sort of regulation or requirement around it with the Joint Commission. So I'm going to share some with you towards the end that I think will be exciting for you. But for when I started, we first pulled the ICD-9 and later ICD-10 codes, and then we went through each of those charts to make sure that they met NHSN definition. And so it was, I would say, not perfect data, but it was better than just the coded administrative data. But as you know, it's not really feasible to do on a large scale. So how did you measure NV-HAP, Marcia?
So the NV-HAP for my study, what I did was I looked at the readmission data from our minus our status information that was provided, and just looked at the readmission diagnosis as to what it was and whether it was a pneumonia or sepsis related to a pneumonia.
Okay.
That's what I did for my project, and I've been working with the hospital with building, because we did not have any kind of report that automatically looks at NV-HAP. And so using the data that you and Dr. Baker have provided related to the use of the ICD codes, et cetera, in building it. And the challenge was getting past that. We're not just looking at coding for aspiration pneumonia. We're looking at not present on admission pneumonias, and that rationale, so that when we build this report, that when it gets to the point, if and when it gets to the point that we need to report these out, that we'll have a report built that's appropriate and will match up, and we won't have to redo it. So that's what we looked at. I did the same regarding the use of oral care tools. Sometimes they'll do a spot check at my hospital, so where we're at, or asking the nurses about it. And also just doing audits, manually looking at documentation. So that's a lot of our just different process and outcome measures, way to look at it. And so how to develop a role of protocol, et cetera. On the left-hand side is a generic version of an educational infogram. We blurred out. So yes, these are examples from my facility. We just blurred out, like I said, infogram on the left, and policy or protocol, nursing practice guideline on the right. And again, basically going back to that other slide where we pulled the grid from the American Journal of Infection Control May 2020 supplement, which gives you basically the instructions. Like I said, that's the roadmap. You need to know what to do. That's the roadmap for you, and use that as our baseline for instructions. And really, that was the big thing, was to get everybody switched to good oral care tools. So for me, with that hard bristled toothbrush that fell apart, I had to go and show that toothbrush to a board member at one of our hospitals and say, look, this is the toothbrush we're giving our patients. And he was absolutely shocked, and explaining that we're basically throwing money away when we're just using mint flavored blue water. It's not doing anything. And that for the American Dental Association, we really need to have an antiseptic, and really needed to fight to get the buy-in for those tools. And that's where I started. So how did you, Barbara, get started with your tools and change?
It's one of my favorite stories, Marcia. As you know, it's hard to get sometimes something that costs more money than what we're paying now. And so I invited some of our leaders to our NV-HAP committee meeting, and I gave each of them a toothbrush and toothpaste and the blue water, and talked about the patient experience, and asked them to go ahead and have the same experience that our patients are having. And so they put those brushes in their mouth and they were spitting the bristles out. And before they left the room, we had the okay to purchase new equipment. So that was a pretty fun one. I don't know how they let me get away with that kind of stuff, Marcia.
But it's definitely the way to capture their attention. And so when we were talking about outcome measures or process measures We were talking about oral care being the key intervention to prevent the NV-HAP. So we need to know that they are doing oral care, and a lot of us are on Epic. So this is just showing that, for documentation, we were asking that our staff document their oral hygiene that is being done. So what are some things that you have found most helpful to engage staff in patient education? I know I've had some questions recently about engaging the CNAs or PCNAs or unlicensed assistive personnel, because sometimes, like for this, nursing, or usually nurses or respiratory therapists are the ones that are the target audience for this type of a topic. But how do we engage our unlicensed assistive personnel who might be the actual ones that are helping support oral care? How do we do that?
We had this one of the first things during our gap analysis when I was speaking with our staff, that I realized the nursing assistants were not getting the same level of education and information as our RNs. And so although the RNs had gotten information about what causes pneumonia, the nursing assistants had not. And because they really didn't understand the role of oral biofilm and how we can easily disrupt it with some good toothbrushing oral care, and how important that is to prevent pneumonia, until we told them that, they really didn't understand. And so we held classes for them, and they became my best champions, I would say. They were so proud of the work they were doing. They were able to feel like their job was important. I had one nursing assistant approach me in the hallway about a week after a class that she had attended, and she says, I used to come to work as a nursing assistant, and I felt like I did the work that nobody else wanted to do. I did the things that were not important because I'm not an RN. She goes, now I feel like I come to work and I'm here to make a difference. I'm here, and what I do can save lives. And she said it's just totally turned around her view and perspective of her job and her role as part of the healthcare team. So I do think it's probably one of our biggest untapped potentials, is really tapping into our unlicensed staff who deliver the majority of this care. Maybe not in the ICUs, not all ICUs have them, but certainly outside of the ICUs, which is where 3/4 of our NV-HAP occurs.
So what are the existing resources that we can use?
I'm really excited to put this together for this presentation, and I found a few new ones, Marcia, while I was doing this. I did want to call attention, and these are all live links, and I believe you'll all get a copy or have access to these slides. But the first one is a brand new oral care for healthcare setting toolkit from the CDC, and it's based on the VHA program of oral care in their hospitals. That's one thing I forgot to mention on all those things that have worked. The VA put together a group called HAPN, Hospital-Acquired Pneumonia Prevention by Engaging Nurses, I think is what HAPN stands for. They did some really great work, reduced their NV-HAP, and it was so well received that they actually rolled it out to all of the VA hospitals. So that is in place right now already. But that's where the CDC got that the information for that toolkit. So again, if the CDC posts something on the HAI website, we should be paying attention to that. That's definitely a sign that things are turning towards that. There's the National League for Nursing. This is a brand new one, the second one. It's actually a course for clinicians on preventing non-ventilator associated hospital-acquired pneumonia. And then there's the implementation guide from the VA is next. And then the one we talked about, the NV-HAP implementation guide from APIC is here. Again, these are all free for you to upload, download, share, and use. This is a link to the Joint Commission Quick Safety that we spoke about. This is a brand new one too from AACN, non-ventilator hospital-acquired pneumonia prevention for critical care nurses, and it's an education CE offering. Again, looked like it was free and clear. And then the last thing I wanted to share with you was this NV-HAP calculator. Again, this is provided by the VA. They are publicly funded, and so what they post on their site is free to all. And lucky for us, we have access to this. So if you click on this link, it will give you an Excel spreadsheet that you can download and save or on your computer. And this is a cost calculator. So you can see this first worksheet is the baseline, and you can put in how many admissions, how many cases, and it will calculate the cost for you. So I put in 5 cases in month 1, and you can fill in the months and the years, etc. And then this was the cost of the hospital. If you total it, start your program, the second sheet of this is, it looks just like this, but you can collect it going forward. Now this only collects cost. The money, like $40,000 is what is estimated. But what it doesn't share with you are all the other costs and impacts that we talked about. So we'll talk about that in a second. But I thought that was really, again, this is a free resource for you. And then one of the other elements of an oral care program is you need to have some sort of a change management plan or model. We know that no matter how great our evidence is, if we have the perfect toothbrush and the perfect antiseptic and all of those, if we don't get people to actually use them, then it's not going to reach the patient, and we're not going to be successful in our implementation. So really, change management ends up being the key to all of these elements and puts them all together. So I recommend finding a model and using it to sort of provide that roadmap. All the things that Marcia and I have talked about will fit right into it, but you need some sort of a structure to hold it together and help provide you guidance as you move along. I've used several different ones, Marcia. I've used ADCAR. I don't know if you're familiar with that one. That works well. The Kurt Lewin change model works well. I know Cotter's 8-step change model is another good one. I have not used that one. I don't like the idea of 8 steps. I don't know about you, Marcia. But the other one I've used very successfully is the influencer model by the folks that wrote Crucial Conversations. I found that to be very helpful. So I would just
say that one, I agree with the influence model. That seems the most natural, and I think it matches up with the nursing process the best.
It does, and it makes sense why we need to talk, personal ability and motivation, social ability and motivation. I mean, all of that, really easy to plug in our implementation plan. So a big question that Marcia and I get, and seems to be a real barrier for many of us, is how do we get administration to listen to us? How do we get them to understand why this is important and why we need the resources to put an oral care program in place? Because oral care doesn't sound very important when you just say it like that. So I would, Marcia and I are going to just briefly go through this. I'm a little bit conscious of our time, Marcia. We have about 10 minutes left. So just briefly, I would say, make sure when you speak with your leadership that you show how your project is really aligned with the organizational goals. So if your organization is really focused on sepsis, they're really focused on mortality, then go to them and say, I have a project that can reduce hospital-acquired sepsis by 20%. I have a project that can reduce length of stay, that can reduce readmission. And then when they ask you, say, we're going to prevent pneumonia by implementing oral hygiene. So I would come at it from, now that I'm wise and old in my years of this, if I had it to do over, if I could go back right now, that's how I would approach it. So all of these things have cost associated there, because NV-HAP by itself, Marcia, it's like invisible, isn't it, to our leaders?
Yes,
Um,
yes.
because
I only got
NV-HAP,
buy-in when I started talking about the readmission, the impact on readmissions, and we needed to do this as an intervention to prevent and decrease the 30-day readmission rate.
yes. So by starting with something like that, and honestly, NV-HAP impacts all of these outcomes. You could even have an NV-HAP dashboard with NV-HAP cases, how many got sepsis, how many started antibiotics, how many passed away, how many had surgery and then got pneumonia afterwards, how many days did they stay, how many were readmitted. I think we could really get a lot of
And I think the other key here is that
are you there, Marcia? Marcia?
as an administrative champion to help move things forward, just to obtain that goal of getting every patient in my hospital system a good toothbrush. Went back to get my DNP just to get that. But administrative champion or sponsor is a very key person.
Yeah. Yes, you're right. And I would also say to start small and then scale up. We started on one med-surg unit at our hospital, and within 3 months, my leadership was saying, we want you to spread this everywhere because the outcomes.
Exactly.
Yeah. So that's a good way to do it. Even just say, let me do a pilot. And if it doesn't work, then we won't do it. I mean, really put yourself out there. I'm very confident in the implement, in oral care to be able to make a difference and make sure all the things we've talked about. Don't be afraid to tell them what you really need to be successful. It's better that they hear it up front. So 3 things that I want to call your attention to and things to be watching in the future. NV-HAP measurement has been one of our big barriers, and I'm excited to say that there's now a new electronic surveillance tool that will make it possible, and it's accurate, and it's been validated and verified, that gives us now the ability to track and trend. The study that I mentioned at the beginning with Dr. Barbara Jones and Compass, they use this electronic surveillance tool. They have another study that validates the tool, statistically validates it, and it's much more accurate than using administrative data alone. So this is really exciting. This, for the very first time, by inputting, uploading this algorithm to your Epic or Cerner or whatever you use, you'll be able to automatically generate your cases of NV-HAP. So this is something you want to look for. This is also open access, including the supplement with that includes that algorithm and all the details you need to work with your IT people. So make really good friends with someone in IT right now, because this is going to be something obviously you'll need help with. But wow, how exciting will this be? And I really think, Marcia, this is going to be a game changer. I think CMS has been waiting for a way that they could be more objective and that all hospitals could measure the same way. And this is the first time we've had that ability. So watch that in the future. I really see this moving toward a CMS thing. The second thing is there's a new partnership now with NDNQI and Epic. So that's Press Ganey owns the nurse data, nurse quality. Can't remember what those all stand for, but it's nurse sensitive indicators. And for the first time, Epic has a way to embed those within Epic. So again, the first time that those who have Press Ganey and Epic will be able to include in their reports things like, right now they've started with just 5, and NV-HAP isn't one of them, but I am working on getting them to add that. But anyway, it's a trend, and it's definitely something to watch for the future. And then lastly, there's a new emphasis on the non-device related hospital-acquired infections. I just put the snapshot of a Shea article in here, the next frontier of healthcare infection. And it's no wonder, with the #1 hospital-acquired infection is not related to devices. So we know, again, you can sort of see where this is going, and I was excited to share that with you. So important points from today, and then we're going to open it up. I think there's probably few enough people, maybe we can even open up the mics. But #1, NV-HAP is the most common hospital-acquired pneumonia, and hospitals need to monitor and establish programs. I think that's all why we're on your line today. Oral hygiene with toothbrushing at least twice daily should be the minimum standard. Don't forget your BiPAP patients. These patients are 3 times higher risk for NV-HAP than patients without BiPAP. So remember them, and we're on this with ReddyPort people because they have a tool that will help you. Marcia and I don't sell things. We just sell evidence-based practice. We don't sell toothbrushes. So we're just here to support the evidence. But if you have questions about something that might help you more successfully deliver oral care to those high-risk BiPAP patients, and please, you can speak to our sponsors. And remember, there are existing resources to help you influence leadership. And I hope that you take advantage of all those links. Check those out. I think there's a lot in there. We don't need to reinvent the wheel. A lot of work has been done already. Be willing to take it and run. So, Marcia, did you have any last words, or do we have anything in the chat?
I do not see anything further in the chat at the moment. I think this is a really great overview and wrap up. It's always good to talk about and share the new evidence and support and see where things are going.
Yeah.
I'm going to unmute everybody. So we have a few left. I know we've gone over, and people have their schedules, but if we do have some time, so whoever would like to verbally ask a question, we've unmuted everybody.
I think it was amazing. It was amazing content. I thought it was a very valuable presentation.
Awesome. I wonder, from people who are still on with us, if you could put in the chat, are you interested in maybe a second webinar that spends more time on actually how to implement something? I'm just wondering what other education needs or questions that you might have that maybe we could do a follow-up. Okay, people are starting to write in.
Mm-hmm.
Thank you for the presentation. Trying, pushing hard. Any content would be great. Follow-up webinar. Okay.
Awesome.
I see Doug Johnson had a hand up there for a second.
Okay, I just wanted to say thank you for answering my questions in the beginning. Fascinating information. And we are looking for an oral program and having an oral care fair. So I will present some of the information you gave us in that. So thank you.
Fantastic. Thank you for sharing.
It looks like Karen has her hand up.
There is a question here about, notice the standard of care for toothbrushes were soft bristled. Is there any more information on that, or is any soft bristled toothbrush sufficient?
Again, going back to the American Dental Association, we recommend that if possible, it should be ADA certified, because that's been through an approval process to make sure that things like bristles don't fall out and that it's of good quality. but there's definitely a lot of those out there. You don't have to spend an arm and a leg on toothbrushes. Probably more than the 2-cent disposable ones.
I can say with the soft bristle toothbrush, when we were first looking at it, we were having a hard time finding the toothbrush that actually said that it was ADA. But we just got it out manually and felt the bristles and looked at it ourselves. That's how we did it.
Okay. We have dentistry part of your organization. Oh, that's fascinating.
Yes. Cleaning grout.
Yes. Yes. My gosh.
Oh,
That's so hard. You know, we had oncology patients that refused to brush their teeth because they would make their gums bleed. And so, of course, as you know, oncology patients are really at risk, right, for infections. So when we got the soft bristle toothbrush, the oncology patient pneumonia rate went way down because they were able to use the brushes. So products do matter. They're not everything, but they really do matter. Well, I know we've gone over time, but I just want to thank everybody for joining us. Marcia, it was so lovely to work with you on this. Thank you to ReddyPort for giving us this opportunity to share evidence-based practice and hopefully encourage our listeners to go out and brush teeth, prevent pneumonia, save a life.
Barbara and Marcia, thank you so much. This was utterly fascinating. And I really appreciate what you've done as far as the education side and bringing it to the forefront. All the attendees, thanks for dealing with the link issues. And we're going to make everything available, as Stephanie was just saying, shortly. And that way you can pass along to other colleagues easily, so to help build interest in your own organization. As someone had asked earlier, so this is the first of several upcoming sessions, and part of the outgoing emails that we're going to send later today, early tomorrow, is we'd like to get your feedback specifically. What else would you like us to address in the next educational session that we have? Either that we didn't have time, or you wanted to go deeper into a particular topic. We really want to make this as relevant to you and your organization as we possibly can. So please let us know that. And meanwhile, we will be following up with you, providing materials and doing the best we can to come out to your facility, do Zooms or WebEx to show you how have we been able to provide access to BiPAP patients so that you can leave the mask on and do all of the oral care that Marcia was detailing earlier without risking desaturation at all, which I realize sounds impossible. That's kind of the whole point. So thank you all very much. We look forward to meeting you and hope you have a great week.